How's it guys? Welcome back to my channel. We're going to be discussing ECGs. To understand an ECG, you need to understand the conduction of the heart. So that's where we're going to start. So to begin the ECG and the conduction of the heart, where it all begins is in the top of the atrium. So this is the right hand side and this is the left hand side, because obviously the patient's left and right. Where it begins is in the SA node. So that stands for sinoatrial node. It's not really important what it stands for, but that's where the conduction begins. It starts there and it makes the atria contract. So all the atria contract and push blood into the ventricles. So these are the ventricles, these are the atria. Once the blood has been pushed out of the atria and into the ventricles, the valves close and then the ventricles contract. So there's another node that's over here. That's called your AV node or your atrioventricular. So your atria and ventricular node, when that contracts, it sends conduction all the way down here and back up the ventricles, causing a much bigger contraction, which then pushes blood into the lungs and pushes blood into the rest of the heart. So that is pretty much the simplified version of how the heart contracts, and then that happens every single time it beats. So it conducts from the SA node to the AV node. From the AV node it pauses and then pushes through to the ventricles. Once that happens, it then pauses for a bit and then it redoes it again from the SA node. Let's move to an ECG. Right. So what you see here is the typical ECG. You'll see a whole bunch of lines, a whole bunch of up and downs and all those sort of things. What we're going to try and do is to just explain to you what each little line means. Alright, so the first little line we see, or the first little bump we see, is called a P wave. Then we have a Q wave, an R wave, S wave, and a T wave. So PQRST. Alright, P is for the atria contracting. So that is the SA node is contracting. That just pushes blood into the ventricles. Then you have the QRS, or the Q wave, R wave, and S wave. That is the contraction of the ventricles. And once the ventricles have contracted, you then have the T wave, which represents the repolarization of the heart, which means the heart is getting reloaded, or it's getting primed, or back to the point where it's able to contract again. So that would be the normal view of the heart. So this view that we're looking at here, this is, well, lead 2. So what that means is that there's multiple views of the heart. So the front or the back or the top or the bottom or that sort of thing. This is a very typical lead. It's something that we generally look at because it's what we normally look at, and it kind of, it makes it easy to recognize, so that when we see it, we are very familiar with it. So now that we've kind of gone through the conduction of the heart and we have kind of gone through what an ECG looks like and how to see what it does, let's try and make more sense of what we're seeing. More like the question of, why is the P wave going up? Why does the Q wave start down and then go up again and then go down again? Why? You see, so like why is the T wave positive? And all those sort of questions I can explain to you in a moment. So if we come back to this, there's something called Einthoven's triangle, which is a big triangle like this. And what it means is that it is the way that we see the heart. It's kind of the way that we look at the heart. So this is lead 2. So from the negative to the positive, it's kind of like an eyeball that's looking in this direction. So when we see conduction move this way, which means from the negative to the positive, we see a upwards wave. When we see a wave go from this way to that way, so from positive to negative, we'll see a negative deflection. And when we see one that goes directly towards this, so not positive or negative, we see a up and down at the same time. Well, not straight straight after each other. So when we are looking at an ECG, we will see first the SA node fires, and we see a P wave. You notice how it's not very big, you notice how it's positive. That's because it's going from negative to positive, and there's a movement of conduction, and so we see a little small positive wave. Then there's a little pause in the AV node, which is got some other name, but for now not so important. It has a little line that comes out here that kind of is like a pause part of the heart, and that's why we kind of see a little bit of a negative Q wave, which is why we see Q waves. So Q waves shouldn't really be there, they're not normally there, but when they are there, that's kind of what it is that it's pausing of the heart so that the atria can fill the ventricles. Once that's happened, we see a really big R and S wave. What that is that we're seeing a really big positive wave is because we're seeing this massive conduction going down the center of the heart, and then what we see is it going back up the sides of the wall. And so what happens here is that we see a big positive wave, but then it starts going backwards. Remember, from positive to negative, we see a negative slope. So we see a big positive, and then a smaller negative, and then it goes back to flat. So that kind of explains the QRS. Then we have the T wave, which is the repolarization, which is the heart getting back to the point where it can fire again or it can contract again, and that is a movement of electrons or so sodium and potassium moving back into where it needs to, and that kind of shows going through the heart in the same direction, and that's why the T wave is positive as well. So to finish off the triangle, we have a positive up here, we have a negative over there, and we have a positive over there. That isn't really important for you right now, but this would be the view of lead 3, and this would be the lead of view 1. So if you're looking at an ECG machine, you'll have the option of choosing lead 2 or lead 3 or lead 1. So that's a basic 3-lead ECG. And when you are looking from different leads, you'll see slightly different, positive or negative lines, depending on which direction it's moving in correlation from where you're looking. And so that's why we typically look at lead 2, is because it kind of goes down the side of the heart, and we are able to see better what movement is showing with what. Alright, let's talk about Ecg Paper. Each square has a square inside it, and this is how we measure how long, let's say, like the P wave is going for, or the duration of the QRS, or the height of the T wave, and that sort of thing. So each tiny little square is 1 millimeter. Alright, each millimeter is equal to 0.04 seconds. So 0.04 seconds. So that means that this whole line from there to there is 0.2 seconds. So now when you see a big block, you know it's 0.2 seconds, and each tiny little block is 0.4. So let's have a look at another ECG. Or back to the previous one. Alright. So whenever we look at a P wave, remember the first little positive wave in lead 2, it should be about 0.12 seconds. So that's 3 little tiny blocks. 1, 2, 3. There we go. So that would be a normal duration of a P wave. A QRS should be no longer than 1 or 0.1 second. 0.1 second. So that's less than 3. So that's 1, 2, it's less than that. So then that will be a normal QRS. When it's more than that, it's called a broad QRS, and then there's probably something wrong with the ventricles, because when it's broadened, it means it's taking longer to go through the muscle, and it's something that we can talk about later. But that's when you get a bundle branch block or something like that, where the conduction through the ventricles is delayed. Then you have your T wave, and your T wave's normal duration is less than 0.1 second. Alright, so how do you work out the rate? How fast is this heart rate going? What you want to do is you want to find a R wave, remember this tall wave, that is closest to one of these lines and count how many blocks are in between this R wave and that R wave. So your R interval. So that's almost there. So that'll be 1, 2, 3, 4. So what we do is we take 300, and we divide it by 4. You can use your phone to calculate whatever you want to use, and that will give you a heart rate of 75. So that's normal. If a heart rate is less than 50, you have something that is called a Bradycardia. So less than 50, you have a Brady, which means slow, and cardia means heart. If it's greater than 100, you have a tachycardia, and tachy meaning fast and cardia meaning heart. If you want to work out if it's too fast or too slow, you count between the RR wave and you divide how many large blocks by 300. So if it's more than 100, you'll have a tachy, and if it is less than 50, you have a bradycardia. Those are two relatively common rhythms, which you'll see. The first couple of steps to analyze an ECG is that you need to look at all of the waves by themselves and make sure that each one is following each one. So questions would be is there a P wave before every QRS, and is there a Q wave after every P wave? That is going to help you work out whether you have a heart block or a first degree, second degree, or third degree heart block, which we'll discuss at a later stage. Questions like how long is your QRS? Remember, it shouldn't be longer than 0.1 second. It can go up to 0.12 seconds. So if it's longer than that, then you have a broadened QRS. And that's something also to take note of. And then you also want to take note of how big is your T wave, how big is your P wave, are they flat, are they looking abnormal? You are also wanting to see whether it is regular. So the way you can assess if something is regular is you take another piece of paper, all right, and you put a mark here, and you put a mark here, and then you move it like this, and you say, do the RR waves remain consistent? And they do. So that is also a really important thing to do so that you can make sure that it is regular, because if it's irregular, there's something else completely different.